Good morning. My name is Dr. Satin Patel at Fertility Specialist of Texas. And today I wanted to give you all an overview of pre-implantation genetic screening, what's more commonly known as PGS after IVF.
So what is PGS? What does it stand for, and what is it?
So PGS stands for Pre-Implantation Genetic Screening. And essentially, it's a new technology that our practice has started to utilize, which in conjunction with in vitro fertilization, commonly known as IVF. Whereas in the past, with IVF, we would stimulate a female to produce multiple eggs and inseminate eggs with sperm to make embryos, culture out the embryos, and transfer potentially multiple embryos. However, the PGS technology allows us to perform a specialized biopsy at the placental region of the developing embryo to determine its genetic makeup. It's essentially gives us a genetic blueprint of every embryo, allowing us and the embryologist to help select the most optimal embryo to transfer in efforts to achieve pregnancy.
So what is it? How is fertility specialist involved in the process of PGS? What is it we actually do?
So our embryology team, they're highly skilled at performing these specialized biopsies in the trophectoderm layer of the embryo, which is a part of the embryo that becomes the placenta. And they perform these specialized biopsies on these day 5 embryos, what we commonly refer to as blastocysts, prior to freezing them using a specialized technique. And these biopsies are then sent to our partnering genetics laboratory in order to obtain that information. And roughly takes about 5 to 6 days for the results to come back, and these results guide us in terms of which embryo to transfer for pregnancy.
So in really, really simplistic terms, how does doing PGS help with IVF success rates?
Well, I feel that PGS has really revolutionized how we practice medicine in terms of IVF. In the past, we would transfer potentially multiple embryos at various time points in development in hopes for pregnancy. PGS allows for really a more sophisticated analysis of an embryo and really vetting it out prior to allowing it to even become a pregnancy. So what it's translated to is putting back only one embryo at a time, hence making twins and triplets very, very uncommon, and that translates to a healthier pregnancy for the most part. Most miscarriages, about 90% plus miscarriages, occur due to the embryo having a genetic problem, and PGS can detect the vast majority of these defects, hence dramatically decreasing a woman's risk of a miscarriage. So in essence, it helps women get pregnant faster and really reduces miscarriages dramatically, allowing for just a more pleasant process and a quicker process.
Do you encourage your patients to use PGS?
Absolutely. I would say about 90 to 95% of all my patients doing IVF today are using PGS technology.
Is there any time that you would advocate against using PGS, or is that pretty much anyone who's using IVF, you would encourage them to do that?
Well, traditionally in our scientific community, PGS was strongly encouraged for patients that are getting into the mid-30s and beyond. However, we've gotten to the point now that even in younger patients, we pick up abnormalities. For example, Down syndrome. If you look at a woman's risk of having a Down syndrome pregnancy, the highest is the older a woman gets, for example, getting into the 40s. However, if you look at the absolute number of Down syndrome pregnancies conceived, it's actually in the late 20s, because more pregnancies are occurring at that age. So then that's just one example of a genetic abnormality. There's numerous abnormalities that can occur. So in my practice, I encourage all our patients to do PGS regardless of age.
So what does PGS detect in terms of, because we've heard about PGD as well. So what does PGS do?
So again, there's some terminology distinctions there. PGS stands for Preimplantation Genetic Screening. So it is a generalized screen on all 23 pairs of chromosomes to look for potential duplications of chromosomes, such as trisomy 13, which is having 3 copies of chromosome 13, or having just 1 copy of a chromosome, because the embryo needs 2 copies of each of these chromosomes that are intact in order to be viable and healthy. It picks up these sort of things. Now, PGD has to do with diagnosing a particular genetic defect that could be passed on from generation to generation. For example, cystic fibrosis or sickle cell. These are particular mutations that can be passed along from generation to generation. They're what we call autosomal recessive mutations, meaning both men and women, you have 2 copies of chromosomes. So one half inherited from your father and the other half from your mother. So usually you could be inheriting a mutation, but the other parent could compensate for that deficiency and the patient appears just fine and without the disease. But if 2 carriers for particular mutations happen to reproduce, 25% of the children are potentially can be affected by that disease, and various diseases can be very devastating for couples. So the way we approach this is that when a patient comes to see us initially, we encourage them to do preconceptional genetic screening, which consists of just a routine blood test to see if he or she is a carrier of a particular mutation, and if he or she is, then we test their respective partners, if applicable, to see if they are carriers for the same mutation. And if they are, then it's imperative, in addition to the PGS technology, to look for generalized genetic defects in the embryo, we can also designate whether an embryo could potentially have the disease before transferring it back, thereby potentially preventing the disease from ever occurring. So it's very, very impactful.
You basically change the generations, the complete family tree, basically, by eliminating this disease.
Absolutely. It can have tremendous impact.
So are there any concerns, and I know this is probably a frequently asked question, about doing this kind of biopsy to do the screening? Are there any concerns about damaging the embryo when they're taking a few of the cells from the part of the embryo that creates the placenta?
So there are theoretical concerns about compromising the integrity of the embryo when you are taking a biopsy of the embryo. Now, that being said, prior to how we do this now, where we biopsy embryos on the 5th day, PGS was performed on the 3rd day. And at that point, you were actually biopsying a larger portion of the embryo and thereby had greater risk to the embryo. We feel that the way that our center does this now, and the high degree of skill of our embryologists, that the risks are actually now quite minimal and much, much less than it had been in the past.
Are there any moral or ethical concerns with PGS?
So that's a very personal question in terms of whether it is a right fit for you. An alternate application of PGS involves trying to select a gender. And because when you are getting this genetic blueprint, if you will, of the embryo and looking at all the pairs of chromosomes, one of the sets are the sex chromosomes. Thereby, if the embryo is XX, that embryo would be destined to become a female, and if it was XY, it'd be destined to become a male. And it is a common request now for couples to come in and request family balancing. For example, if family may have a son and want to have only one more child and want to experience the joys of having a daughter, this is actually quite common as well. And again, it's a right fit for some patients. For some patients, they're against that. We absolutely respect your wishes with that. And again, we are most focused on the health of the embryo, of making sure that we do everything we can to help you have a healthy baby.
So just on average, if a patient, say they have 5 embryos that we send out for testing, about how many of those, just in broad terms, would come back abnormal?
Great question, and that's highly variable. And the biggest factor to determine that has to do with maternal age. The male and reproductive platforms are quite different because men produce sperm on a daily basis. The chance of having a genetic abnormality in terms of an aneuploidy is actually quite rare from the sperm side. But on the female side, all the eggs are produced before female's even born, and it's around 7 million eggs prior to birth. And the eggs and the genetic material in the eggs are actually stagnant throughout life. So the older a female is, the higher the prevalence of genetic abnormalities there are in the eggs. So for example, if a female is 25 years old and goes through IVF, then we expect about 90% on average of the embryos to be normal. At 30, 80% to be normal. But interestingly, once you get to about 35, usually we find about half of a woman's embryos are genetically abnormal. It's very striking. And as you go further down to 40, for example, 80% plus of embryos are abnormal. So PGS does give you more relevance and is more impactful the older a female is.
And just kind of talking about the age portion, I know it's a little bit of a departure from PGS, but why does age impact the egg quality and the embryo quality so much?
We feel that the impact of age on egg quality and thereby resulting embryo quality mainly occurs due to the genetics concept. Because what happens is, and this gets a little bit more complex to answer in terms of molecular genetics, but you have, in order for an egg to be fertilized by sperm, its genetic content needs to be split in exactly half. And that's what we call, it involves a process called meiosis. And as that occurs, as women get older, that equal division of genetic material just doesn't occur as reliably as it needs to. And as that doesn't occur as consistently and as reliably, then there can be an uneven distribution of genetic material that results in the divided cells. And that's essentially, for example, what trisomy 13, 18, or 21, which commonly known as Down syndrome is, where, for example, an egg may have a duplicate copy of chromosome 21, and when it's fertilized by a sperm, now it has 3 copies of chromosome 21, thereby calling it a trisomy 21, resulting in abnormal pregnancy.
So we have a question from Lavana. She wants to know, do you know of any cases where abnormally tested embryos were still transferred and resulted in a normal pregnancy?
So this is an area of controversy in our specialty. So basically, when you're biopsying an embryo, the assumption is that the biopsied portion of the embryo is accurately representative of the entire genetic potential of that embryo. There's this concept of what we call mosaicism, meaning are we potentially getting just a suboptimal snapshot of this embryo? Or can this embryo potentially autocorrect the defect and fix itself, thereby resulting in a normal pregnancy? It has been reported in the literature. Now the genetic screening companies that we work with, and we very carefully select who we partner with because these results are important in terms of a patient's outcome. They will, if requested, will report to us whether the embryo is a low-level mosaic, meaning is the potential for this correction better, or a higher level mosaic, meaning that this is probably a bad idea to be transferring this embryo back in. In our experience with our patients, most of our patients would not tend to be transferring mosaics because they simply don't want to take the chance that could potentially set them up for problems and require more interventions during the pregnancy itself.
Right, because they could also increase their chances of miscarriage, right, and have to go through IVF cycle again, and just
exactly
the emotional, the financial, just the heartache of all of it, and then possibly having a child with complications as well. So I would think probably our common practice is, like you said, to transfer just the healthy
embryos.
Okay. And we have just a couple more minutes. Just really quickly for anyone who's just joining in, can you just do a snapshot one more time about what PGS is and kind of why you recommend it for your patients?
Absolutely. So to summarize, PGS, which stands for Preimplantation Genetic Screening, is a newer technology that we're utilizing on almost all our IVF patients. and it has revolutionized IVF in the sense that it allows us to perform specialized biopsies on embryos and get a genetic blueprint, if you will, prior to selecting which embryo to transfer back, thereby allowing us to help significantly improve a patient's chances of getting pregnant and dramatically reducing the risk of a woman's miscarriage.
And we have time just for one more question. Lavana has a follow-up. If the embryos have not been deemed as mosaic, but simply abnormal, would your feedback be the same?
Absolutely. So if an embryo is deemed as being abnormal, so we highly encourage patients to not transfer an embryo back in because we understand the emotional sequelae of what can happen, and we want to do everything we can to help our patients have a good outcome.
Perfect. Just pop in real quick, guys. Sorry, I've been off camera. I just wanted to thank everyone for participating, and if you have any questions, please feel free to post them in the comments, and I will touch base with Dr. Patel and get those answers for you. But everyone have a wonderful Friday and a wonderful weekend, and thank you so much for joining us.
Thank you.